The following podcast is part of a certified educational activity titled The New Immuno-Oncology Era in Early Stage Bladder Cancer, Readying the Modern Urology Practice. Access the entire activity and complete the post-test at peerview.com/FPT860. Downloadable slides and practice aids are also available.
Hi, everyone, and welcome to the new immuno-oncology era in the early stage bladder cancer, readying the modern urology perspective. I'm Neil Shore. I'm the medical director of Carolina Urologic Research Center and the chief medical officer of urology and surgical oncology for Genesis Care in the U.S. It's a really great pleasure for me to be joined with my good friend and colleague, Dr. Matt Galsky. Matt's from the Icahn School of Medicine at Mount Sinai in New York City and the director of genitourinary medical oncology at the Tisch Cancer Institute in New York. Uh, we know the impact of immunotherapy on the treatment of metastatic urothelial cancer. It's been well established really since 2016. It's incorporated in the treatment paradigms and virtually all national and international guidelines. But now there's an ongoing, burgeoning role for immunotherapy in early stage disease. So today we're going to be exploring some of the developments that can inform the use of checkpoint inhibition and to really appreciate the multidisciplinary optimization of that management now for both NMIBC and MIBC. And it's really an integral part of the evolution of multidisciplinary care, which ultimately provides patients with the best of care. We'll discuss practical points that should help you in your daily management, diagnosis, and therapeutic selection. So let's begin. So the goals of our session today is understanding immunotherapeutic strategies in bladder cancer and early stage disease. That's what we're really going to focus on. Um, what are the skills that you need within your clinic to do this well and personalized treatment plan? And provide also some guidance on how to create a team-based management because there are some unique suite of skills and understanding, education to manage and teach and educate patients about adverse events associated with immunotherapeutics, such as checkpoint inhibitors, and particularly in early stage bladder cancer patients. So the challenge is in non-muscle invasive bladder cancer, well, like a lot of disease states, and if we stick to geo-oncology, we always say how prostate is very heterogeneous. Well, NMIBC is very heterogeneous too, and therefore we need to understand the unique issues regarding selection and management of the different therapeutics. Immunotherapy, one really needs to have a good handle on the immune-related adverse events. Matt Galsky is going to talk more about that, and we'll talk more about its implication for the MDT. Now, patients who have high-risk NMIBC, these are the ones we are particularly focused on because they have the highest percentage of progression. As you see mentioned here, 25%. Bladder cancer, low risk, intermediate risk, high risk, it has the scourge of recurrence. It's the progression that really concerns us. For those are the patients who can go on to have disease progress outside the bladder, have metastatic disease, and ultimately have a lethal pathway. Now, intravesical therapies after resection to URBT have clearly been shown, certainly with BCG and other intravesical chemotherapies, to reduce recurrence and progression. But there's still an unmet need because we have BCG unresponsive patients. We have the BCG shortage, and we'll talk more about that. And then the issues regarding receiving appropriate maintenance schedules, and the guideline recommendations are there for the strategy for maintenance based upon pioneering work that was done with the SWOG trial. But nonetheless, fewer than half of our patients complete adequate maintenance BCG. I mentioned shortages. Ultimately, what are our goals are really to avoid cystectomy, or at the very least, delay it for as long as it is deemed safely possible, because radical cystectomy, albeit an important surgical intervention, is nonetheless of major consequences to patients and their cancer journey. So what about additional therapies that we can use? We'll talk more about that. Here's the IBCG. They do great work in defining, who are patients who have received adequate BCG or inadequate BCG. And the indications, as you see listed here, for receiving induction, and then ultimately for patients who receive induction, proper maintenance, and then are deemed either unresponsive at the bottom orange, versus those who have late relapse after getting either an adequate or a less than adequate dose of BCG. And this particular last group, the less than adequate, is an ongoing area of key interest. But our trials to date, especially for the BCG unresponsive, are based upon the definitions of a proper induction, 5 of 6, maintenance of 2 of 3, 3 months out, and continuing that same regimen over typically 6 months for a 2 to 3 years. So here's a sort of an overview combining guideline statements from AUA and SUO, US based here, for NMIBC. And we do our TURBTs, we get the histopathology, we want to make sure we have good interpretation, good resection, potentially a repeat resections, but some guidelines, there's level 1 evidence for it, especially for T1 disease, and arguably if it's a TAG3 and you felt that you didn't do a complete resection. At the bottom, there we have the trifurcation of risk: low risk to high risk, intermediate risk, basically everything falling in between the low risk and high risk definitions, the roles for BCG and for maintenance. Now, what's really exciting to me is the fact that we have a lot of other avenues within the field of clinical investigation, the trial landscape, looking at BCG versus intravesical chemotherapy, gemdosi, looking at the IL-15, or also known as ALT-803, that really pioneering work done by the Quilt trial, which is before the FDA now, on this super agonist, CR rate of 71%. Other um, mechanism of action of therapeutics, such as FGFR inhibitors. This is the Thor phase 2 study. And again, all of these here are for BCG unresponsive. Adstiladrin, the rad interferon syn 3 nadofaragene feridonovec, has now been approved by FDA in December. We're expecting a commercial launch of this for BCG unresponsive patients sometime at the end of summer 2023. And this was real kudos to great work done by the SUO CTCs. But we're going to talk about immune checkpoint inhibition. So the Keynote 57 was pioneering the large phase 2 study, which ultimately demonstrated in this particular cohort for patients in cohort A, CIS, with or without papillary disease, who were BCG unresponsive. Cohort B, I'm going to show you in a minute, data recently presented at ASCO GU 2023. And these are open label patients receiving pembrolizumab, 200 milligrams Q3 weeks, and the rigorous evaluation with cystoscopy, cytology, and imaging, and ultimately looking at disease-free survival, the DFS, at 3, 6, 12, and now out to 24 months. And the basis of this particular cohort A, you see the Kaplan-Meier here. This led to the FDA approval in January of 2020. It is the only immune checkpoint inhibitor to date approved for BCG unresponsive patients. And so what we see here is about a 40% CR at 3 months, extending to a CR of nearly 20% at 12 months, and the duration of response out to 16.2 months. So this has now been on the market, readily available. And of course, this is to obviate the moving to cystectomy if it's felt that it's safe to do so. Now, cohort B was just presented again at ASCO GU 2023. It'll be again presented at EAU 2023. And this was this cohort B, this is papillary now. So papillary and also some patients with T1, but no CIS. And there's a breakdown between looking at PDL based upon the CPS assay for greater than 10, less than 10. But what you see here is that regardless, what one sees a very nice response that these patients at 3 months, their disease-free survival 54, 43, 39%. And one sees, interestingly, particularly in those who were PDL positive, a really marked benefit. But as we go on, these are still relatively small numbers, but I think it's really important that this data has come across, and we'll further be reporting on survival benefits as well. Cohort C, this is looking at combinations for similar populations in the BCG unresponsive, CIS with or without papillary disease, T1, TAG3s, and combining with pembrolizumab, TIGITs and LAG3. And this is an ongoing trial. It's currently enrolling. And I think this is further exciting to try and see if we can have combinations with the checkpoint inhibitor and vibostolimab, which is the TIGIT, and favezelimab, which is the LAG3. So these are additional data that are coming forward, and it's a trial in progress. So what about other options? And so I mentioned earlier this notion around a device. Some folks call it the pretzel, but really, because it looks like a pretzel, it's the size of 2 quarters overlapping. And it's an intravesical drug delivery system that allows a sustained release in the TAR-200 of gemcitabine. And the Sunrise 1 is a phase 2 study looking at 200 patients, the cohorts combining one cohort of the device with gemcitabine slow release, again given intravesically, so not systemically, and an immune checkpoint inhibitor known as setrilimab, and then a monotherapy arm of TAR-200 and a monotherapy arm of setrilimab. So a very interesting and unique way of approach. In the phase 3 trial, sponsored by AstraZeneca, I'm honored to be the co-PI with Maria DeSantis. We've completely finished accrual for this trial. This is in BCG naive patients, high risk NMIBC, so high grade T1 CIS. You see the inclusion here. A 3-arm randomization, traditional BCG induction but no maintenance, and durvalumab, a checkpoint inhibitor, as well as a second arm of traditional induction maintenance BCG plus durvalumab. And this was given for a year's time. And then a traditional control arm of BCG induction and maintenance, a primary endpoint of disease-free survival. This will be the first of 3 important phase 3 trials to read out. There's the Keynote 676, which is an almost identical trial design, but using pembrolizumab, and then the CREST trial, which is a subcutaneous checkpoint inhibitor known as sasanlimab. And these trials are going to arguably, once they have enough events, give us, and if they're positive, offer checkpoint inhibition in BCG naive patients. Of course, we'll look to see efficacy and look to see a risk-benefit analysis, particularly by safety profile. So just a quick case in here, NMIBC, 68-year-old patient, high-grade disease, lamina propria invasion, muscles not involved, repeat TURBT by the guidelines, by level 1 evidence, no residual tumor. So some of the questions, so what do you do now? What intravesical approaches do you take? Is the patient's BCG naive, BCG unresponsive? Particularly, let's assume he's BCG unresponsive here. If there's a shortage, what do you do? And what about, this, how do you deliver immunotherapy? And of course, clinical trials are always a good solution, especially if you're studying some of the things we just talked about. Matt, any quick comments on this case?
So I think this is a particularly tough one because this is a patient with a high-grade T1 tumor. And we know that the approval for pembrolizumab thus far is for carcinoma in situ with or without papillary disease. So you showed us the results for papillary-only disease, and we'll wait to see if there's an FDA approval there. Of course, cystectomy is a standard of care in a patient like this, but there are intravesical options that are out there and sometimes pursued.
Yeah, great. Agree with all of that. So let's kind of switch over now and talk about another area that I think is incredibly interesting, very exciting now for all of us who take care of bladder cancer patients. We talked about, high risk NMIBC. A lot of trials are going to be coming out in intermediate risk NMIBC, and we talked about the role for IO and other novel mechanisms of action. But what about our patients where we know they absolutely do not want to have a cystectomy? Or maybe they just don't have a performance or an anesthesia risk for a cystectomy. As many of our patients who have muscle invasive disease, not all, but many, are deconditioned, elderly, and oftentimes have a lot of comorbidities and may not be able to, tolerate such a procedure. Nonetheless, with better, high volume centers, we are doing much better. But I think it's still it's a easier decision, especially for patients who have dysfunctional, crippled bladders. So, what about the notion of bladder preservation using a multimodal approach, or what some would call trimodal, aggressive or a maximal TURBT, and chemoradiation, and now the possibility, and I'm going to review, adding in other novel forms of mechanism of action, immunotherapy being one of them. So, without a trial, chemoradiation and maximal TURBT, and by maximal, we're really talking about getting down to fat and really being aggressive, trying to debulk the tumor as much as possible, and obviously doing it in a way as safely as possible. And so, if there's an incomplete response, if the patient receives chemotherapy and radiation, now it's important to bring in your radiation oncology colleague, your medical oncologist. There are several different chemotherapeutic regimens that one can choose from. There's a standard amount of agreement on typically 4 different regimens globally. Sometimes there are some other approved therapies, such as vinflunine, that are given in Europe. But if the patient has an incomplete response, arguably could still go on to completion cystectomy. But if the patient does have a response, and manages to continue to have good long-term follow-up. And these are some of the happiest patients I've seen in my practice. So I mentioned the importance of a complete, very thorough resection. The chemotherapy is given for its sensitizing impact for radiation benefit. And I think for the location of the right lesion, not well suited for someone with prostatic urethral or bladder neck involvement, but certainly for patients in other areas of the bladder, the dome, the base, the lateral walls, posterior wall. And some would argue against giving it to certainly for patients who have disease of the level of the urethral orifices, especially if there's hydronephrotic change. But we need more randomized trials, and that's what we're going to talk about right now. So, harnessing immuno-oncologic therapy in a trimodal setting. Here's a trial. It's a phase 2 called the Immuno-Preserve. It's using a checkpoint inhibitor with a CTLA antibody, so durvalumab and tremelimumab with concurrent radiation therapy. An interesting and provocative trial given patients who undergo TUR, neoadjuvant combination IO therapy, radiation, and then measuring for response. And this is an ongoing trial. But nonetheless, this trial has demonstrated so far a disease-free survival with an intact bladder of 73%. And given the combination IO regimen, treatment-related adverse events of 31%. We'll talk more about that and the importance of understanding how to deal with that. A phase 2 study, again, looking at trimodal bladder sparing is pembrolizumab and systemic gemcitabine and concurrent hypofractionation. Again, here we have a median follow-up of 14 and a half months and a 1-year bladder intact disease-free survival rate of 88%, a complete response rate 12 weeks post-RT of nearly 80%. So looking, of course, at any of the systemic toxicity and local voiding control, but nonetheless, these are patients who are doing very well maintaining their bladders. Here's a phase 3 trial that I've been honored to be part of. This is a global trial known as the Keynote 992, and this is looking at patients with muscle-invasive disease who want to opt for bladder preservation. They don't want cystectomy, and what we're seeing here is a randomization 1-to-1 of Pembro, the Q6-week regimen, and chemoradiation, again, medical oncology choice on the different chemotherapeutic regimens versus a placebo-controlled and a chemoradiation therapeutic regimen. So I'm very excited about this. There are some additional ongoing randomized trials. You see them listed here at the bottom. Very important because, again, going to cystectomy is an easier call, especially when patients have tremendous voiding symptoms or their bladder cripples, so to speak. But this is really an unmet need, and these are important prospective trials for us to get the evidence that we want to see. I mentioned the TAR or the TAR 200 platform earlier. Here's the another bladder sparing approach, the phase 3 Sunrise 2. There are 4 Sunrise trials that are ongoing. In the Sunrise 2, this is the TAR 200 with gemcitabine and the PD-1 inhibitor citrilimab versus more the traditional concurrent chemo radiation option in a 1-to-1 randomization. So very provocative study looking at bringing in this intravesical gemcitabine exposure and an IO versus more traditional chemo radiation therapy approach. So with that, let me hand it over to you, Matt, and let's talk a little bit more about what some of the more traditional, but some of the more interesting and provocative work that's coming out on both neoadjuvant and adjuvant strategies in IO.
Thanks, Neil. So lots going on in the non-muscle invasive and trimodality therapy setting, integrating immune checkpoint blockade. And so let's move to another setting in the treatment of muscle invasive bladder cancer, which is the neoadjuvant setting. So we know that neoadjuvant chemotherapy is a standard of care for the treatment of patients with muscle invasive bladder cancer based on 2 large randomized clinical trials. And we also know that there's room for improvement here. And one way to improve upon neoadjuvant therapy, of course, is to add additional treatments like immune checkpoint blockade. In the neoadjuvant setting, we do have the ability to do phase 2 studies because we have an intermediate endpoint of activity, that's pathological complete response. We don't have that in the adjuvant setting, and we'll talk about that a little bit more. So historically, in the adjuvant setting, we've needed to rely on randomized studies. But in the neoadjuvant setting, we could do phase 2 studies and get a sense for whether or not we're moving the needle at all. And we have a number of phase 2 studies now which have explored single-agent immune checkpoint blockade or cisplatin-based chemotherapy plus immune checkpoint blockade in the neoadjuvant setting prior to cystectomy, looking at pathological complete response as a primary endpoint. The studies with single-agent immune checkpoint blockade, I think, were really quite intriguing when we first saw the results. In the 2 studies, which really we saw the results for first, were the PURA-1 study, exploring 3 cycles of pembrolizumab prior to cystectomy, and the Abacus study, exploring 2 cycles of atezolizumab prior to cystectomy. And those studies reported pathological complete response rates of 42% and 31%, respectively. And, for just 2 to 3 doses of single-agent immune checkpoint blockade followed by cystectomy, quite intriguing because that's really competitive with what we've seen with cisplatin-based chemotherapy in the past. And so that led to enthusiasm about trying to combine immune checkpoint blockade with cisplatin-based chemotherapy, seeing if we could push those pathological complete response rates up even higher. So now we have a number of data sets, a number of phase 2 studies which have sought to do that. And what we see with path CR rates is that the path CR rates do maybe seem to be a little bit higher, maybe more in the 40 to 50% range compared to the 30 to 40% range. So we're not necessarily seeing additive effects when we combine platinum-based chemotherapy plus immune checkpoint blockade in either the metastatic or the neoadjuvant setting, although there does seem to be some increased depth of responses. And of course, that's where the time to event endpoints like event-free survival and overall survival are going to be important. And for that, we need randomized studies. So we have a number of randomized studies exploring whether or not we should add chemotherapy and immunotherapy together in the neoadjuvant setting, or proceed just with neoadjuvant cisplatin-based chemotherapy, followed by cystectomy. And each of these studies has an adjuvant component as well. And so we'll start to see the readouts of these very important trials within the next few years. It poised really to change neoadjuvant treatment for the first time since the phase 3 studies were done decades ago that really put neoadjuvant therapy in the map. We also have this unmet need of neoadjuvant treatment for patients who are quote unquote cisplatin ineligible. Traditionally, we haven't had treatments in the perioperative setting or in the neoadjuvant setting for this unmet need. And a number of phase 3 studies launched in this setting as well. These studies differ from the studies that I just mentioned in that because cystectomy alone is the standard of care, that's the control arm. And then we have studies exploring neoadjuvant immune checkpoint blockade followed by cystectomy versus cystectomy alone, and some studies integrating neoadjuvant immune checkpoint blockade plus the antibody drug conjugate enfortumab vedotin followed by cystectomy based on the response rates with that combination in the metastatic setting, which have been quite intriguing. So one thing that we see with neoadjuvant therapy, of course, is pathological complete response in the primary tumor specimen in a subset of patients. And I just showed you that that can be achieved with cisplatin-based chemotherapy. It can be achieved with immune checkpoint blockade alone. And perhaps when you give the two together, maybe a little bit even higher likelihood of achieving that endpoint. And so that really raises the question, coming back to Neil's presentation on trimodality therapy. Well, what about bimodality therapy? Can we achieve cures in muscle-invasive bladder cancer by maximal TURBT plus systemic therapy? And do we need local therapy with radiation or cystectomy at all? This has been a notion that's been toyed around with for really decades. And shown here are some results from Dr. Harry Herr, really showing in a single center experience that there are a subset of patients who probably are cured with this approach. But there have been multiple barriers to advancing this treatment paradigm, including some concerns about the disconnect between clinical staging and pathological staging. And now we have a new generation of clinical trials really putting this on the map again and asking the question, if we're very rigorous about clinical restaging and we really assess clinical restaging as a biomarker to inform risk-adapted, personalized treatment decisions in bladder cancer, can we move this paradigm forward? So this is one of these studies. This is HCRN GU 16257, was updated at ASCO GU 2023. And in this study, patients underwent TURBT, patients with muscle-invasive bladder cancer who were cisplatin eligible, got 4 cycles of gemcitabine, cisplatin plus nivolumab, and then underwent clinical restaging. And clinical restaging was defined by cystoscopy, biopsies of any visible tumor or biopsies in a template in the bladder, urine cytology, and imaging of the bladder, particularly MRI unless otherwise contraindicated. 76 patients enrolled on this study. 72 patients made it to clinical restaging. There were some patients who couldn't have the clinical restaging performed. Among the patients with clinical restaging, 33 had no evidence of cancer on those assessments, and that was defined as a clinical complete response. And in patients who achieved a clinical complete response, they had the option to not pursue cystectomy and to receive maintenance immune checkpoint blockade, or they could undergo cystectomy. If patients didn't have a clinical complete response, then cystectomy was recommended. So you can see here 32 of the 33 patients with a clinical complete response opted for no immediate cystectomy and rather for maintenance immune checkpoint blockade. And you can see the swimmer's lane plots outlining the outcomes of those patients. The dark blue lanes indicate that patients have an intact bladder with no evidence of local recurrence. The lighter blue lanes indicate that patients have had a local recurrence followed by cystectomy with the yellow boxes. And then the arrows at the end indicate that patients are still alive. So with rigorous clinical restaging and a uniform definition of clinical complete response and an integrated chemotherapy and immune checkpoint blockade strategy, one can identify patients who fare well and who might be able to have their bladders left intact. And here you see on these Kaplan-Meier curves the metastases-free survival or overall survival of patients based on achieving a clinical complete response or not. And so this seems to identify a subset of patients who fare well, who might be selected for bladder sparing. But of course, we need additional data to validate these findings. So how about the adjuvant setting? We've spoken about neoadjuvant immune checkpoint blockade, and despite all of the data that I showed you, we don't yet have randomized phase 3 data results to support routine use of neoadjuvant immune checkpoint blockade. But we do have phase 3 studies in the adjuvant setting, and we actually have 3 phase 3 studies that were pretty similarly designed. We have IMvigor10, which randomized patients with muscle-invasive bladder cancer at a high risk for recurrence after surgery to adjuvant atezolizumab versus observation. We have the Checkmate 274 study randomizing patients to nivolumab versus placebo. And we have the Ambassador study randomizing patients to pembrolizumab versus observation. These studies were designed really quite similarly with some nuances regarding the randomization to observation versus placebo, some nuances in terms of the primary endpoints, which included disease-free survival in some studies or disease-free survival plus overall survival in other studies. The eligibility criteria for these studies was really quite similar. And high risk for recurrence after surgery included patients who had received neoadjuvant therapy but had residual cancer, T2 disease or higher in their surgical specimen, or patients who hadn't received neoadjuvant chemotherapy, had T3 or higher disease in their surgical specimen, and were quote unquote cisplatin ineligible. Importantly, these really were the first generation of phase 3 studies in the adjuvant setting to include patients with upper tract urothelial cancer as well. So here you see the primary endpoints of Checkmate 274. This was data updated at ASCO GU 2023. You can see the co-primary endpoints of disease-free survival in the intent to treat population, where the hazard ratio was 0.71 in favor of adjuvant nivolumab. And then in the subset of patients with high PD-L1 expression, that was a co-primary endpoint, you see the effect size is enriched in that population with a hazard ratio of 0.52 in favor of adjuvant nivolumab versus placebo. And of course, adjuvant nivolumab was approved by the FDA in this setting based on the results of Checkmate 274. We also saw updated results at ASCO GU from Checkmate 274 in terms of secondary and exploratory endpoints. And the updated ASCO GU was really based on much longer follow-up compared to the initial publication of the Checkmate 274 study. So at the time of the initial publication, the minimum follow-up was 5.9 months, and now we report minimum follow-up of 31.6 months. And you can see across primary, secondary, and exploratory endpoints in the intent to treat population, incredibly consistent results with successive follow-up, with hazard ratios across those endpoints in the 0.7 range. And in patients with high tumor PD-L1 expression, you see hazard ratios in the 0.5 range across all of those endpoints. Of course, it's important to see the stability of the effects over time, because remember, this is adjuvant treatment and it's fixed at 1 year. So really what we want to see is the outcome, the benefits of treatment persist long after the treatment is stopped. And indeed, that's what we see. What about safety of adjuvant nivolumab? Of course, lots of experience with immune checkpoint blockade in the metastatic setting. We even have experience with immune checkpoint blockade, as we've heard from Neil, in the neoadjuvant setting, or rather in the non-muscle invasive bladder cancer setting. How about in the adjuvant setting? Post-cystectomy, patients are recovering from surgery, And you can see here that treatment related adverse events occurred in 18% of patients treated with adjuvant nivolumab grade 3 or higher, and 7% of patients treated with placebo. You see the specific types of adverse events in the figure, and no new safety signals have emerged with longer follow-up. So the side effect profile is very similar to what we see in the non-muscle invasive bladder cancer setting and in the metastatic setting, but not enhanced in this postoperative setting. Quality of life similarly has been assessed in Checkmate 274. And importantly, when randomizing patients to an active treatment versus a placebo, really what we want to see in a group of patients who by definition should not have a disease-related burden because there's no evidence, there's no macroscopic evidence of cancer. What we're really looking for is no detriment to quality of life with the addition of an adjuvant treatment. And indeed, that's what you see, and with quality of life results summarized here over time in both the intent to treat population and the subset of patients with high tumor PD-L1 expression. So we spoke about trimodality therapy. We spoke about adjuvant immune checkpoint blockade, but what if patients have received concurrent chemoradiation and had high-risk features on their initial tumor? Should we be giving patients who have received concurrent chemoradiation adjuvant immune checkpoint blockade? This has become a very common strategy for the treatment of stage 3 lung cancer, where patients also get concurrent chemoradiation and now they receive adjuvant immune checkpoint blockade. And so we don't really know the answer to this question yet in bladder cancer. Neil presented a series of phase 3 studies which are integrating immune checkpoint blockade both into the concurrent chemoradiation portion of treatment and also to the adjuvant portion of treatment. We're beginning to see some pilot data, though, suggesting at least this is a feasible approach. So this is called the NEXT study, and this is a phase 2 study of adjuvant nivolumab after patients with muscle-invasive bladder cancer have received concurrent chemoradiation. What we know from the initial results of this study are that this approach is feasible in that small sample size, but seems to be intriguing in terms of the outcomes here. And so very interesting what we'll see with the concurrent chemoradiation plus IO trials, because the contribution of adjuvant therapy to those trials is certainly important as well. We need to personalize decisions in the adjuvant setting as much as possible, because by definition, when we administer treatment in the adjuvant setting, we're administering systemic treatment to patients, some of whom have already been cured with surgery. And of course, if we had the ability to measure which patients have micrometastatic disease, then we could apply adjuvant treatment in a much more precise way. The IMvigor10 study, unlike the Checkmate 274 study, did not show an improvement in disease-free survival or overall survival. There's a number of potential reasons for that. Ultimately, why the trial showed different results isn't entirely clear. However, the investigators from that study asked the question, well, what if we could determine which patients had microscopic metastatic disease? Would the results have been different? And so they used a molecular residual disease assay. And of course, this involves whole exome sequencing of patients' primary tumors, identifying mutations in that individual's tumor, and then developing a PCR panel to detect those alterations in the plasma. This is a tumor-informed bespoke test, so it needs to be developed for each individual patient. And if there is detection of those alterations in the peripheral blood, then that's known as detectable ctDNA, or the presence of molecular residual disease. So incredibly intriguing findings, certainly findings that require validation in our efforts to bring precision medicine to the adjuvant setting. And so there are a number of attempts now to try and validate these findings and establish clinical utility. One of those is the IMvigor11 study. And IMvigor11 is really designed to replicate the results seen in that retrospective analysis of IMvigor10. So enrolling a very similar patient population in patients with detectable ctDNA, randomizing them to atezolizumab versus placebo, with overall survival as a primary endpoint, because And the retrospective analysis of IMvigor10, that is the population that benefited the most from adjuvant atezolizumab. Within the US cooperative group system, we've taken slightly a different approach, and this is known as the MODERN study. In the MODERN study, we'll ideally be launching within 2023. And this study enrolls patients post-cystectomy, similar patient population to Checkmate 274, and patients undergo Signatera testing after surgery. And if there's detectable ctDNA, then patients are randomized to adjuvant nivolumab, standard of care, versus adjuvant nivolumab plus a LAG-3 inhibitor, trying to escalate treatment in patients with detectable ctDNA. In patients with undetectable ctDNA, patients are being randomized to adjuvant nivolumab versus observation with initiation of nivolumab in individuals who convert from an undetectable to a detectable ctDNA assay during follow-up, and there's a non-inferiority design integrated into that portion of the study. And so ideally with these studies seeking to prospectively assess the value of ctDNA in informing treatment decisions, we'll move into the next era of adjuvant immune checkpoint blockade in urothelial cancer. Currently, the treatment algorithm is shown as follows. Patients with muscle-invasive bladder cancer ideally undergo a multidisciplinary evaluation, because if you've heard from us today, there's lots of choices and lots of emerging data and lots of emerging choices in this space. If patients are candidates for radical cystectomy and they want to proceed with radical cystectomy, of course, that is a standard of care. And if patients are eligible for cisplatin, well, cisplatin-based neoadjuvant chemotherapy is standard. In patients who receive neoadjuvant chemotherapy and have residual disease, then adjuvant immune checkpoint blockade is a potential standard of care based on the surgical findings. In patients who are cisplatin ineligible, currently proceeding directly to cystectomy is still standard of care, but based on surgical pathology findings, adjuvant immune checkpoint blockade could be administered. If patients don't want to proceed with radical cystectomy, or if there are medical or surgical contraindications to proceeding with surgery, then of course, concurrent chemoradiation trimodality therapy is an established treatment approach, and we've heard that this requires a multidisciplinary treatment with maximal transurethral resection, involvement of medical oncologists, involvement of radiation oncologists, and of course, for every one of these clinical decisions to be made, there is the option to pursue clinical trials. And there are clinical trials in virtually every one of these spaces right now, given the market activity, the market increase in activity in drug development for bladder cancer over the past several years. So let's talk a little bit about a case. This is a 48-year-old man, excellent health, an athlete who develops hematuria on and off. He attributes this to running frequently, ultimately has a workup, has a cystoscopy, a bladder mass is identified. He undergoes a TURBT. He has clinically localized muscle-invasive bladder cancer. He has good renal function. He has no contraindications to neoadjuvant therapy, so he gets 4 cycles of gemcitabine and cisplatin and undergoes radical cystectomy. And on evaluation of his surgical pathology specimen, there's pathological T3B disease, and he has 0 out of 32 lymph nodes involved. So of course, the question arises, is there anything else that can mitigate the risk of recurrent disease in an individual like this? And of course, now we have data from Checkmate 274 that in patients who have received neoadjuvant cisplatin-based chemotherapy and have pathological T3 or higher disease in their surgical specimen, there is a role for adjuvant immune checkpoint blockade, and certainly would be a reasonable approach for this young, fit patient. So Neil, let's talk about some approaches for team-based collaboration in management of bladder cancer. Of course, this is increasingly becoming a disease where multimodality therapy is integrated and the expertise of multiple specialties are needed to optimally manage patients.
Yeah, I think that's absolutely the case. And so, we continue in all forms of cancer to talk about the importance of, shared decision making. And so I think we're all doing, regardless of your specialty, medical oncology, radiation oncology, uro-oncology, geneticists, pharmacists, the importance of getting the patient and the patient voice and to be active participants and discussing things in such a way that they can make their most informed decision. So much of your presentation was moving us towards the notion regarding precision-based therapy, which it really comes across all cancer types. And then ultimately, that's what's going to allow patients to make their best decision along with their caregivers. And regardless of the result, hopefully it's a positive result, but it's going to, have them being in charge of their decision making. And then there's the ultimate importance of their own psychological well-being and their adherence to therapy, and confidence in the provider because they were integrally involved in the decision. There's a spectrum, and many of us have patients who just say, look, just tell me what to do. I don't, you just tell me you're the doctor. But I think more and more, given the plethora of avenues for knowledge and patient education and advocacy groups, patients will really want to have a full-throated understanding of all that's listed on that tablet on the right of this slide. What are their medications? What are the pros and cons of interventions, whether they're surgical, radiation, chemotherapeutic, chemoradiation combinations, IO? How will it affect their quality of life? And it's so the quality of life factor, the prevention of complications, the prevention of progression, and of course the prolonging of survival become all the key components. We've talked about our classic way we think about the MDT with urologists and oncologists, but now we recognize the importance of radiation oncology, interventional radiologists, getting tissue specimen, understanding that if we're dealing with imaging positivity, is it a second primary or not? Getting adequate tissue as well as blood-based sampling in order to do MRD or residual disease assessments, and even the basic next-generation sequencing of bladder cancer tissue, whether it's in the primary organ of the bladder or metastatic, gives us information about their status in addition to their PD status, and there's controversy regarding the implication of that, but I still think most of us like to understand it, but then also their tumor mutational burden, issues regarding microsatellite instability, FGFR incidence. These are all going to give us better tools to inform our patients. So it's the entirety of this team, and of course, it's all of the healthcare team. It's the physician assistants, whether they're nurse practitioners or physician assistants, RNs, MAs, the pharmacist. The complexity of what's out there is exciting because it's giving us more tools in our armamentarium, as we're so fond of saying, but it does lead to a certain amount of complexity and the requirement to stay on top of all of the changing clinical trials, the therapeutics, the biomarkers, and arguably even imaging. And therefore, having that multidisciplinary team, I think it provides our patients with their best opportunity. I also would be remiss if I didn't mention that because certain types of treatments, and particularly immune-related adverse events, may really require that regularly we talk and not feel uncomfortable in engaging our dermatologist, our endocrinologist, a pulmonologist, gastroenterologist to help facilitate optimal care. I think what's particularly compelling to me is I've seen still many of our colleagues, urology in particular, radiation oncology, not yet have developing a certain level of comfort regarding immune-related adverse events, educating patients on the importance of prompt recognition, and then ultimately the management. I always think particularly unfortunate is if there is an avoidance of even having these conversations. And I think we're in most parts of the world, not all, where you do have the luxury to have access to these therapeutics and even clinical trials, it's a conversation that has to ensue. So, the immune-related adverse events that we see, and I would think it was really kind of interesting as you look through the data that you presented, Matt, and I did as well, that these are sort of the most common, and actually, dermatologic rash, itching, pruritus, the GI. Fortunately, it tends to be low grade, but you can see other aspects besides the diarrhea, and inclusive of hepatitis or transaminitis and hyperamylasemia. Thyroid effects are very common, very common. A lot of hypothyroidism, occasional hyperthyroidism. Fortunately, it seems that the pulmonary pneumonitis effects are nowhere near as common as I think that at least in my perspective, they were initially reported. Although, of course, an inflammatory response can occur in virtually every organ system. So from head to toe, brain to skin, thyroid, parathyroid, lung, heart. But these tend to be the more common organ systems. And I think if there's a really proper, good, collegial, communicative pathway, then patients can get treated with great results. So maybe at this point, like hand it over to you, Matt, and talk a little bit about, the timing and grading of adverse events, strategies that have worked for you at Mount Sinai, and with, your patients, your nursing team, and the urology referral base.
Absolutely. So there is a little bit of variability in the timing of when these various immune related adverse events are most likely to occur. But I think probably the more important rule of thumb is that toxicities related to immune checkpoint blockade are unpredictable. And they're unpredictable in terms of what organ system might be affected, and they're unpredictable in terms of the timing. So you can see on this slide that skin toxicity tends to occur on the earlier side. Renal toxicity, which is not very common, tends to occur on the later end of the spectrum. But really, we see immune-related adverse events infrequently after a single dose of immune checkpoint blockade. And we see immune-related adverse events after someone's been on treatment for a year and a half. But most frequently occurs within the first 6 months. The optimal approach to managing immune related adverse events is probably early recognition. And that probably is true for most of the organ systems affected. And there are wonderful resources available in terms of managing immune related adverse events. There's the ASCO guidelines, there's the SITC guidelines. These are really nice proscriptive recommendations for management of immune-related adverse events. That said, it's important to keep in mind which toxicities one can treat through and which toxicities would not be a good idea to treat through. Even if you don't remember everything about the management of immune-related adverse events, that's useful information to keep in mind because that also helps one remember which side effects need to be evaluated much more promptly and when you need patients to come in the next day instead of their next visit. And so that's, of course, where the grading of immune-related adverse immune-related adverse events come in. And for grade 1 side effects, for most organ systems affected, this is something that can be treated through. And of course, these side effects are usually very mild and sometimes intermittent. For grade 2 immune-related adverse events, this is really when we hold treatment and when we have a low threshold to start corticosteroid treatment. And sometimes, depending on the organ system involved, there can be a brief period of close observation, but oftentimes steroids are required. And for grade 2 immune-related adverse events, this is a situation where restarting treatment at some time after the immune-related adverse event has resolved and steroids, if they were given, have been tapered off, then it can be considered. For grade 3 and 4 immune-related adverse events, generally stopping treatments required, initiation of corticosteroids is required, and usually we would not recommend restarting treatment in those settings, although it depends again a little bit on the particular event and the details of that event. For some toxicities, also important to keep in mind, treating through that toxicity can be considered because it's not expected to recover, but it could be managed. So, what's an example of that? Well, something like hypothyroidism. Oftentimes, we'll see a little bit of thyroiditis followed by hypothyroidism. And that pattern is pretty reproducible. And for patients who aren't symptomatic during that transition, continuing immune checkpoint blockade and initiating thyroid replacement could be considered. But of course, for many other immune related adverse events, that really does require holding treatment and involving other specialties for input, both in terms of the diagnosis and the treatment as well. Here you could see in a little bit more detail some of the more common immune-related adverse events in terms of the grading, what constitutes the grading, and what some of the guidelines that I was referring to recommend doing in terms of both the workup and initiation of steroids and how much in the way of steroids. Usually, when we taper steroids in individuals who have had immune-related adverse events, we do that slowly. And that's because as one is tapering steroids, these events can recur. And so we want to make sure that the event has resolved and that we can stop steroids. And if the event, as noted, was grade 1 or grade 2, then potentially resume treatment. So lots to know about immune-related adverse events. It is a team approach to say the least. We need to involve multiple specialties. Our approach has been to try and involve specialists who have a particular interest in managing these side effects so that they become very familiar with them, and in that it's not individuals seeing patients with a side effect that they aren't used to managing, because oftentimes that results in our specialists who help to co-manage patients deferring back to the oncologist. And it's of course important for the optimal management to have specialists who really know in detail how to manage immune-related adverse events related to the organ system that they treat. Um, Neil, in terms of your approach, we talk about involving multiple specialists in the management of immune-related adverse events, and I recognize sometimes that's easier said than done. Even in academic centers, getting appointments with some specialists can take weeks to months. So how do you approach that in your practice?
Yeah, it's a great question, and it's evolved over time. You're right. I think that depending upon where you are, it's sometimes getting a one of our busy colleagues to see a patient. Sometimes it just takes getting on the phone yourself or having that your go-to medical specialist on your text um, um, speed dial, so to speak, which is what I've evolved to. So if I have a patient who I really feel needs to be seen urgently from an endocrine standpoint, or even a dermatologic, which are kind of few and far between on the dermatologic, more on endocrine, occasionally on the GI side, I just can text my colleagues right away and make sure that the patient is seen, very quickly. I think it cannot be underestimated how pivotal our nursing leadership is, both in my clinic and in my research side. I have specific nurses in my research center who are doing IO therapy and specific dedicated nurses within the clinic. They are the ones who really spend the lion's share of the time when an IO is being administered, going over with the patient and their caregivers. Here are the things that you need to be thinking about, and if you are concerned, email, text, or call us right away rather than sort of reflexively going to the emergency room, as emergency room facilities these days are really overstressed and understaffed. So I think that for assuaging the anxiety of many of our colleagues who may be listening to this presentation, as long as the patient and their caregivers are really adequately prepped on what an immune-related adverse event in any organ system in the body could involve, and they contact us, then we can immediately talk about starting high-dose steroids or holding the next therapy or doing other supportive therapies. And in a very, very small percentage of patients, we're asking to get a medical specialist involved right out of the get-go, although that's always something that's good to have within your pathway. So it really is, honestly, it's a team approach. It's educating patients that they understand not to be reluctant to give us, to contact us by email, text, or just come to the clinic.
Thanks. Those are great points. In the point about education and educating patients and caregivers, I can't stress enough. And it's not only education at the time that these medicines are started, but it's constant re-education. Of course, patients and family members are taking in all of this critical information at that initial visit, oftentimes really adjusting to that need for treatment in general and not hearing a lot of what we're telling them about the side effects of treatment. And so stressing the most common symptoms and signs related to immune-related adverse events such that those can be reported promptly, I can't state enough critical importance.
There are great avenues for patient education, SITC, SUO, ASCO, Beacon, the Bladder Cancer Advocacy Network. These are great. This is such a big advance compared to where we were, say, 25, 30 years ago. The access for patients and, just to give them that is extremely important.
Yeah, absolutely. So I'd like to thank you for joining us today. In summary, we've seen evidence that supports immunotherapeutic approaches for treating early stage bladder cancer and representing possible positive alternatives for patients moving forward. Each of these approaches comes with multiple considerations that have to be weighed by the treating clinicians and patients and family members, and really it is best supported by this team multidisciplinary approach that you've heard us speak about. So thank you, Dr. Shore, for this fruitful discussion. I'd like to remind you to download the practice aids associated with this educational activity as a resource for you, your staff, and your patients. And thanks again, and we hope that you found this activity informative and useful for your practice.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/FPT860. This activity is supported through independent educational grants from AstraZeneca, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, Bristol Myers Squibb, and Merck & Company Incorporated.